Our next session, we will hear from Dr. Gita Bhat, a clinical research fellow in the Department of Medical Oncology and Hematology at Princess Margaret Cancer Center, Nazlin Jivraj, who is a specialized oncology nurse and has worked at Princess Margaret Cancer Center for the last 22 years, and Alaa Danab. Alaa is a registered dietitian at the Princess Margaret Cancer Center. And today they are going to talk about maintaining good bowel health in gynecological cancers. I will now turn it over to you, Dr. Bhat.
Thank you, Stephanie, for the kind introduction. Let us begin a very warm welcome to everyone gathered here, and let us begin our discussion on maintaining good bowel health in gynecological cancers. Next slide, please. Yeah, so our discussion is divided into 4 parts, and the first part will be an introduction into what is malignant bowel obstruction. So first up, what is the bowel? So the bowel or the intestine includes the small bowel and the large bowel. Next slide. And what does the bowel do? The small bowel absorbs nutrients from the food that we have eaten, and the large bowel absorbs water from the waste, thereby leading to the formation of fecal matter or poop, as we call it. Next slide. So how does our bowel move? Our bowel moves like an earthworm. These smooth, well-coordinated wave-like movements are called peristalsis. Next slide. And what is bowel obstruction? Any blockade which prevents digested food, liquids, or fecal matter from passing through the small and or the large bowel is called bowel obstruction. Next slide. What is malignant bowel obstruction? Any obstruction caused by cancerous tumors, either by pressing on the outside of the bowel or by growing inside of the bowel, is called malignant bowel obstruction. Next slide. And we have to keep in mind that in women with advanced or recurrent gynecological cancers, especially ovarian cancers, tumor nodules tend to grow on the bowel wall, that is, on the outside of the bowel. These are called peritoneal deposits. You might have come across these words in your CT scan results. So what happens is, as these tumors grow, they press and pinch the bowel wall, thereby causing it to narrow. With that, flatus and fecal matter cannot pass. Also, these tumor deposits on the outside of the bowel form a hindrance to the smooth and well-coordinated movement of our bowel, thereby giving rise to malignant bowel obstruction. Next slide, please. We must remember that malignant bowel obstruction is a common and yet serious complication of advanced gynecological cancers, especially ovarian cancer. Next slide, please. What are the signs and symptoms we have to watch out for? They include recent change in bowel habits, nausea, vomiting, bloating, abdominal distension, and not passing gas. Next slide, please. So herein, let us try to play this video on bowel obstruction and to know what to do if you have bowel obstruction.
Know what to do if you have bowel obstruction for women with gynecologic cancer. In this video, you will learn what to do if you have bowel obstruction. This includes knowing if you have bowel obstruction, how to manage partial bowel obstruction, how to manage complete bowel obstruction, your treatment options, and how to prevent bowel obstruction from getting worse. How do I know if I have bowel obstruction? If you have the following symptoms, you may develop bowel obstruction. These symptoms are no poo for more than 2 days, if this is different from your normal pattern. Bloating, your stomach feels swollen or very full. Not passing gas. Abdominal or stomach pain. Nausea, feeling like you will throw up. Vomiting, throwing up. If you have symptoms of bowel obstruction, your doctor will order an abdominal X-ray or a CT scan to confirm that you have bowel obstruction. The results of these tests will also tell your doctor the type of obstruction you have and where it is located. Bowel obstruction may be partial or complete. The type of bowel obstruction you have can affect how it is managed. How to manage partial bowel obstruction. Partial bowel obstruction is when part of the bowel becomes narrowed. When the bowel narrows, it causes a partial block, which makes it difficult for poo to pass. This can happen due to cancer pressing on the bowels. Partial bowel obstruction can often be managed with changes to diet or with medicine. This will help you to maintain bowel function. How to manage complete bowel obstruction. Complete bowel obstruction is when the bowel is fully blocked. A complete block means poo and gas cannot pass out of the body at all. If you are taking laxatives, stop taking them. This is serious and requires medical attention. Contact your healthcare team right away. If the blockage or obstruction is near the top of the small bowel, you may have nausea and vomiting. You will be asked not to eat or drink anything. To relieve the nausea and vomiting, you may need a nasogastric tube, also called an NG tube. An NG tube is put through your nose and into your stomach. This will help drain fluid and gas from your stomach. Your doctor may give you medicines to control your nausea and vomiting. This will be given to you as an injection or through an intravenous drip, which is an IV needle in your arm. Once your symptoms improve, the NG tube is removed and you will be given sips of fluid. If your vomiting stops, you will slowly be given a full liquid diet. You may also be given medicines to manage your pain. If you continue to have nausea and vomiting, you may need a gastric venting tube permanently or long term. A gastric venting tube is a tube placed into your stomach to remove contents from your stomach. This is done to stop you from vomiting. If the obstruction is in the large bowel, you may have a stent. A stent is a tube that will keep your bowel open. If the obstruction is in the large bowel,
So it appears we have just lost sound for a moment, but we are working on it.
may be given to control the spread of cancer. Palliative local radiation. This may be given to control your symptoms. Medicine to decrease liquid buildup or secretions that are normally produced by the bowel, as well as inflammation or swelling and symptoms such as nausea. IV fluids, which are given to you through a needle in your arm. This will help reduce your symptoms and hydrate you. Medicine to control nausea and vomiting. How to prevent bowel obstruction from getting worse. After having bowel obstruction, it is important that you follow the diet given to you by your healthcare team, take medicines your healthcare team prescribes, tell your healthcare team about symptoms that are new or that have changed. This may include severe abdominal or stomach pain, uncontrolled vomiting, or diarrhea. Tell your healthcare team if you do not poo or pass gas for 2 or more days. Track the number of times you poo and if it was hard, soft, or watery. In this video, you learned what to do if you have bowel obstruction. This included knowing if you have bowel obstruction, how to manage partial bowel obstruction, how to manage complete bowel obstruction, other treatment options to manage bowel obstruction, and how to prevent bowel obstruction from getting worse.
Yeah, thanks for playing that video. So this was one of the 5-part videos that we have from the Princess Margaret Cancer Center, and it's easy to follow and readily available on YouTube. Next slide, please. Next slide, please. Yeah. So part 2 will be on the proactive model of care for maintaining good bowel health in gynecological cancers, and our specialized gynecological oncology nurse Nazlin will lead us through it. Over to you, Nazlin.
Hi, everybody. Thank you, Dr. Bhat, for that very informative presentation on malignant bowel obstruction. So given the significance of bowel obstruction for women with a gynecological cancer, especially those with ovarian cancer, our gynae team decided that because it's such a significant problem, we needed to do something to address this problem. We found that most of our patients would come to the clinic or they would be calling the nursing telephone triage line with symptoms of bowel obstruction. And when we would see them, either they would need to get admitted right away to the hospital or we would have to send them to the emergency department. So reflecting on our practice to manage bowel obstruction, we found that what we were doing was really reacting to our patients' symptoms. Next slide. So our goal was actually to become more proactive in terms of managing our patients' bowel functions so that we could try to see if we could actually avoid an obstruction. So as an interdisciplinary team, we developed a proactive model of care for our patients that are being managed as an outpatient. What we did was we first surveyed our patients and we asked them how confident they felt in terms of managing their bowel function with respect to diet and medications and just general knowledge. Next slide. So what we found were, these were actually 2 comments that really stood out to us, and I'm just going to read them to you. I discovered solutions to my bowel problems only after 4 hospitalizations for partial bowel obstructions. Would have been helpful to know beforehand that this can be an issue with ovarian cancer and how it can be managed with a low residue diet and the right laxatives. Took me a while to learn to be preventative around this issue. More education at the beginning would have helped. So these women actually highlighted diet, medication, and more education that would have helped them. When we reviewed what education materials we actually had in our clinical setting, we found that it was lacking. We actually didn't have enough information. So we worked with our patient education department and with our patients too, and we developed a malignant bowel obstruction package. Next slide. So the package contains pamphlets that are specific for our gynecology patients to know how to maintain good bowel function. So the first pamphlet is knowing literally how to maintain good bowel function. Then our dietitians developed a pamphlet on knowing about low fiber diet for partial bowel obstruction. We then added a Bristol stool chart and some information on the different types of laxatives. And the 5-part video series, one that you just actually watched. And the other ones talk about diet and medication as well. So patients get enrolled into the MBO program based on the symptoms that they are reporting. Next slide. So when our patients come to clinic, they usually have to report their symptoms using an iPad or a paper form or at a kiosk. And these symptoms get reported to the healthcare team, usually just before we bring our patients into the room. When we reviewed what questions were being asked, we found that there was only 3 symptoms that actually related to bowel obstruction, which were pain, nausea, and appetite. So we added on constipation, vomiting, and diarrhea. Next slide, please. So what happens is when our patients report their symptoms, if they rate 3 or more on any 2 of the symptoms, it triggers this secondary bowel assessment questionnaire. And this questionnaire is more specific in terms of, are you passing gas? Do you feel bloated? When you're eating, do you feel full with just a small amount of food? Next slide. So when patients complete the form, it gets reviewed by their healthcare team, and we then determine if the patient needs to be enrolled in the MBO program. If they receive the MBO package, the nurses then provide teaching. We document in the patient's in their electronic chart. And then usually, probably the most important part is we provide proactive phone calls for our patients. So we call them once a week for about a month or 2 months, really depending on their need. Next slide. So with these proactive calls, nurses provide teaching and guidance on laxatives, like which ones to take and how to take them, because it is extremely confusing. There are so many different types of laxatives, and which ones to use can be actually a little bit overwhelming. Next slide. There's also an initial discussion about diet and how to maintain really a low fiber diet and what foods to eat, and which you can see here. These are all foods that are kind of high in fiber. So we talk about what foods to eat and what foods not to eat. Next slide. Most importantly, if a patient actually does have a bowel obstruction, we do have we have our patient case discussion. So it's called our malignant bowel obstruction rounds. And this is where a number of members from our interdisciplinary team come together. We review the CT scans and we have a discussion. It usually involves like our surgical oncologists, our medical oncologists, our dietitians, and so forth. We review the scans and then we talk about what needs to be done for the patient, what would be the best treatment option for them. Next slide. So after implementing the program, we reviewed our patient's confidence level in terms of diet and medication and how to maintain good bowel function. And after being in the program, we did find that their confidence level actually did improve. Next slide. So we're excited to say that we're currently working on developing an MBO app for our patients to report their bowel symptoms to their healthcare team. But probably what's most important to us is that with the success of our program and all of the educational materials that we have developed, our hopes are really to collaborate with other cancer centers just to share the information and knowledge to really help improve patient care, particularly with those that are at risk of malignant bowel obstruction. So thank you. I will now pass it on to Alaa to discuss the importance of diet.
Thank you, Nazlin, and thank you everyone for joining us today. Thank you, Stephanie. As Stephanie mentioned, my name is Alaa, and I'm one of the dietitians at the Princess Margaret Cancer Center. And one of the areas that I practice in is in gynae cancers. So for the bulk of this presentation, I'm going to be discussing eating well on a low fiber diet. I would like to preface with the fact that this diet is mainly to be followed by individuals who are at risk for a bowel obstruction or who have had a bowel obstruction in the past. Next slide, please. So you might be wondering, well, why do I have to follow a low fiber diet? As some of you might know, fiber is present in fruits, our vegetables, our grains, and nuts and seeds. This particular nutrient actually makes it, actually bulks our stool and makes it very difficult for the stool to pass. So if you look at the image below, if you have a narrowing to your bowel, whether from the inside or if you have tumor that's pressing from the outside, fiber bulks the stool and makes it very difficult for your stool to pass. So you might exhibit symptoms that we've discussed about, which are abdominal pain, bloating, nausea, vomiting, or no bowel movements if you're completely obstructed. So following a low fiber diet may actually lessen some of these symptoms. Next slide, please. Yeah. So I've put together some common foods, some common low fiber foods that we should think about. And I didn't even know that that pepper had like a GIF moment, so I apologize for that. So when we look at the vegetables, we encourage that all your vegetables have the skins removed, seeds removed, and stalks removed, because that will minimize the amount of fiber in your particular food. And you want to avoid any raw vegetables. So unfortunately, you will have to avoid things like lettuce, celery, kale, and spinach. So when we think about fruits, same concept, removing any skins, seeds, and membranes. So you are able to choose foods such as bananas, melons, oranges, as long as you're removing the membranes as best as you can, or things like papaya, which is a low fiber fruit. In terms of avoiding the high fiber fruits would come from berries, avocados, pineapples, and kiwi, which have quite a bit of fiber in them, and they're quite fibrous-y as well. Next slide, please. Oh. Yes, thank you. Now, when it comes to the grains and the cereals, you need to avoid things that contain quite a bit of fiber. Any cereal or grain that is labeled high fiber, so something like popcorn or like Weetabix or Shreddies that are quite high in fiber, or like a multi-grain cereal, those would be things to avoid. You are able to choose things such as oatmeal, Cheerios, brown rice, half a cup of brown rice, or 60% whole grain bread, which is lower in fiber. And we will put this together in the next few slides to help see how everything comes together. Next slide, please. The previous slide, sorry. Yeah. Now, when it comes to meats or poultry and fish, these are generally foods that you don't necessarily have to worry about because your protein foods don't necessarily have a lot of fiber. The one thing to worry about and to be very cautious about and potentially avoid in terms of the meats would be things that are in casings. So things like sausages that are in casings or deli meats that are in casings, or very tough meat that can actually, make it very hard for your body to digest and break down. When it comes to things like your beans and lentils, unfortunately, your beans and lentils do harbor a lot of fiber. So those foods are to be avoided, especially your nuts and seeds. But you are able to choose things like smooth nut butters or smooth peanut butters, which are lower in fiber and don't necessarily contain any chunks of nuts and seeds. And lastly, in terms of your dairy or dairy alternatives, again, you don't really have to worry too much about these groups. The one thing to be cautious about and to avoid would be any dairy or cheese, milk or yogurt that has nuts, dried fruits or seeds or large particles of fruit inside. Next slide, please. Now, when it comes to fiber-containing supplements, unless otherwise indicated by your healthcare provider, where you have to be on a fiber-containing supplement for specific health conditions or health reasons, then it's best to speak with the healthcare provider just to be able to see how you can potentially keep on these supplements while maintaining a low-fiber diet. Otherwise, we do suggest that you stop taking any supplements that bulk up your stool. So anything like Metamucil, Benefiber, pectins, psyllium husk, all of these terms are synonymous for fiber supplements that increase the size of your stool. Next slide, please. Now, something that comes up a lot when I'm speaking to patients is the difference between juices and making a smoothie. So in general, when you're making a juice, the act of juicing actually strips away and extracts the pulp, seeds, and skins. So generally speaking, a lot of my patients will tend to juice some of those foods, the fruits or vegetables that are on the avoid list, because you're actually just left with the juice part. You don't have to worry about the amount of fiber because it's just the juice. Whereas when you're making a smoothie, the smoothie is when you're actually putting, your fruits and your vegetables in a blender, and the act of blending is just chopping the fruits and the vegetables, which does not change the amount of fiber that is contained in that beverage. So that's why it's very important when you are making a smoothie to choose low fiber fruits and vegetables, and to only choose maybe 1 to 2 in half cup portions, because you don't want to overwhelm or add a lot of fiber in that in your smoothie. So generally speaking, when you are looking at purchasing a juicer, just make sure you're purchasing a juicer that actually separates the pulp and skins from the actual liquid, because you will be left with the juice part. Next slide, please. Now, a low fiber diet doesn't necessarily mean no fiber at all. If we think about the typical diet, the typical amount of fiber in a diet, we should be aiming at around 20 to 30 grams, depending on the age group that you're in. Now, for a low fiber diet, we're typically aiming for half of that amount, so around 10 to 15 grams of fiber per day. Now, the individual and specific needs are going to be different for everyone, and the specific tolerance is going to be very different for everyone. But generally speaking, we're aiming for around 10 to 15 grams per day. Next slide, please. So I find that it's quite important when you're shopping and you're trying to choose products that are low in fiber. What does that actually look like? So you want to aim to have around 2 to 3 grams of fiber per serving. So if we look at the two products here, we're comparing 2 cereal boxes. So product A, as you can see, per half a cup portion, there are 7 grams of fiber. So that's quite a bit of fiber. It doesn't necessarily fit between that 2 to 3 gram per portion. So that would be something to avoid. For product B, cereal product B, as you can see, for 3/4 cup, there is 1 gram of fiber. And so that would be a good low fiber product to choose, because it fits between that 2 to 3 gram of fiber per serving. The other thing that may be helpful when reading food labels is to look at the % daily value, so to the very right. If we look at product A again, as you can see, for 7 grams of fiber in that serving, that equates to 28%. So when you're using the % daily value, anything that is less than 5% or below would be a good product to choose in terms of fiber, because we're trying to minimize the amount of fiber. Anything that's 10% or above would be a high fiber product, so that would be something to avoid. Next slide, please. Now, when it comes to meal planning can be challenging, especially when you don't really know where to start. So I tend to give my patients this schematic just to give them a framework of how to build on their diet. When you're thinking about the Canada's Food Guide or a healthy plate model, you're still incorporating your fruits, your vegetables, the grains, and a source of protein. But over here, when it comes to the low fiber, we're just making a few tweaks just to abide by some of the low fiber restrictions. So the first step in planning your meals on a low fiber diet would be to select a protein. And the reason being is because, your protein is generally not restricted, right? So we select our protein source. The next step would be to select a low fiber carbohydrate. The third step would then to be building fruits and vegetables into your diet. So selecting maybe 1 to 2 low fiber fruits and vegetables for each of your meals. And each portion would be half a cup portion. And then the last step would be to add your healthy fats. So don't forget to add your oils, a little bit of butter if you prefer. Next slide, please. So I've sort of put some of the recommendations that we've talked about into a sample menu just to be able to see how this all fits together. So if you look at the top, the breakfast, as you can see for breakfast, we're having a vegetable omelet. So we're having 2 scrambled eggs, a 1/4 cup of zucchini, a 1/4 cup of sweet bell peppers, an English muffin, an ounce of cheese, and a cup of juice. And to the very right, I've written in some, notes to remember. So for example, for your vegetables, you want to peel away, you want to take away any skins, and to cook your fruits, any of the vegetables. And for a snack, for example, so you generally want to be having, 3 main meals and snacks in between, especially if you're on treatment when we're trying to maximize your intake as well as your protein. So for a snack, for example, we're having half a cup of sliced bananas and half a cup of Greek yogurt. And generally speaking, I always suggest having a source of protein with your snack. That way it can provide some satiety and it's a good way to bump up your protein as well. And then for lunch, we are having a tuna sandwich. So half a cup of tuna, 2 tablespoons of mayonnaise, 2 slices of white bread, or you can have up to 60% whole wheat bread, and half an apple. And again, remembering that with the apple, we're trying to take away that skin so that we can minimize the amount of fiber. And then for the snack, we're having a couple of graham crackers and a tablespoon of peanut butter. And lastly, for dinner, we're gonna have a salmon. You can season, don't shy away from seasoning or adding spices to your meals because that will help just spice and season things up. Oh, and we're pairing that up with some rice, or you can have half a cup of cooked brown rice, which has low fiber. And then we're having, I know I said there are no salads. Salads are generally avoided, but you're able to have a cup of tomatoes, just chopped, sliced tomatoes with some balsamic dressing and some cucumbers. But please take away the skins, take away the seeds to, again, help minimize the amount of fiber in that meal. So if we look at the total amount of fiber per day, we have 12 grams in total. So again, that fits in between that 10 to 15 grams per day. So this is going to look different for everyone, but generally speaking, I know it's difficult to kind of build your diet, and it's often hard to see what you can do, but this is an example, and I hope it kind of illustrates what we're aiming for. Next slide, please. So some helpful hints moving forward. So the first step, as I mentioned, is eating small, frequent meals throughout the day rather than large meals. And I know this goes without saying, but chewing your foods well. I think we've had some some instances where patients just forget to chew, and that's not a good thing. So keeping in line with that is choosing some, moist cooking methods. So things like stewing, braising, maybe just to help break down some of those fibers and make those foods a bit easier to chew and process, versus something of dry heat like frying or broiling, which can make the food a bit tougher to process. And again, having a lot of fluids, because that will help, again, propel and move that stool throughout your bowel. So aiming for at least 6 to 8 cups of fluid per day. And we're talking about fluids of all sources, so not just water. Water is very important, but if you have a bowl of soup, the soup counts for a source of your fluid. If you have some ice cream, that ice cream also accounts for some fluid, but aiming for at least 6 cups of fluid per day. And experimenting with different foods and flavors, I think that's very important. And sometimes it is challenging, especially when you're first starting off on the low fiber diet, when you're still trying to see what works and what doesn't, but don't feel afraid to experiment with foods and flavors. And then the next tip would be keeping a food journal. And oftentimes I encourage people to keep food journals just to be able to backtrack and see how they feel, especially when we're working throughout the low fiber diet, we're adding new things to the diet. It's just important to be able to write down how you're feeling so that you can actually see and go back and backtrack to see how things are going for you. Now, if your diet is limited, if you're experiencing any, nutrition impact symptoms like a poor appetite, then speak to your dietitian, speak to your healthcare providers about incorporating a multivitamin, just to be able to make sure that your nutrients are met. And lastly, staying active, because activity will certainly help with your bowels and keep things moving. Next slide, please. So in conclusion, as I mentioned, a low fiber diet does not necessarily mean no fiber. I think the amount will certainly depend on your particular circumstances and your tolerance. And I know that, changing, and I really do recognize that changing your diet can be, it's difficult at first, but there are, support systems, there are people to talk to, ask for a referral for a dietitian to be able to provide you with the support and the resources that you will need to move forward with your journey. So that concludes my section. I'm going to pass it off to Dr. Bhat, who will talk about research and NBO.
Thank you, Nazlin and Alaa, for that wonderful presentation. Let's move on to the fourth part, an insight into ongoing research in malignant bowel obstruction. Next slide, please. So good clinical management, accurate information and education, and ongoing research go hand in hand in improving patient care. Next slide, please. So we know that every woman is unique, and every woman's ovarian cancer journey is unique. And there are many questions, such as why do peritoneal deposits form in gynae cancers? Why do only some women go on to have malignant bowel obstruction? Why is every patient unique? So all these are challenging questions that pose opportunities for learning, and we are continuously learning more on ovarian cancer and how it behaves in our patients. So next slide, please. With this vision, and in order to learn more about and understand gynecological cancers and malignant bowel obstruction, we have the MAMBO clinical study for women with or at risk of malignant bowel obstruction. Next slide, please. So what does this study look at? So this study is a clinical study wherein what we do is collect all the clinical information in a very systematic way. We collect data about treatment outcomes, overall survival, response to chemotherapy, nutritional status, and the different types of interventions, be they surgical, be they placement of a stent, treatments that have been given to our patients. Next slide, please. And this study also goes a step further into collecting tissue for research. So what we do is we collect tumor tissue from the surgeries of the patients that have enrolled themselves in the study, as well as ascitic fluid, and do a really deep dive to look at the mutations in the cancer cells in the samples. And another new aspect, an upcoming aspect that we are looking into is the gut microbiome, which means the microbes that live in our gut. What we do is we do a deeper look into them and see does their pattern change over time along a patient's treatment course, along a patient's cancer journey, and does that predict outcomes? So this is very early research and will take a lot of time and plenty of questions to be answered. Next slide, please. Thank you very much. With that, we conclude our discussion. Our special thanks to all our patients and our gynecologic oncology site group interdisciplinary team, especially Dr. Stephanie Leroux, for this opportunity to take part in this symposium. Thank you very much.
Thank you. So we are going to get right into the questions because we have a very lively chat box here and we have a lot of questions. I'm just going to say that if we don't get to the questions now in the next 15 minutes, we are going to follow up with the panelists after, and they have agreed to help us answer those questions after, and we will get those back to you. So first question I have is, can you talk about bowel obstructions from abdominal adhesions from surgery? Is treatment different for these obstructions?
Okay, so I can take that one. Yeah, so post-operative adhesions or like scar formations, as you all said, are also an important cause of bowel obstruction. So if this were the cause, the surgeon would have a look, see if there's any surgical option to try and release these adhesions. And if not, then good oral hydration, maintaining a low fiber diet, laxatives, as well as good physical activity, and making sure that the treating team is in close contact with the patient and carefully following up is a good way to go about this.
Thank you. Next question. This, I think, is for you, Alaa. Will eating a low fiber, as people ask new questions, they scroll up. Will eating a low fiber diet help reduce the chance of a bowel obstruction?
I think this is, and again, Nazlin and Dr. Bhat chime in as well. I think the low fiber diet is to help minimize the risk. Will it prevent? I think prevention is quite it's an absolute term, but the low fiber diet from what we've seen does certainly help minimize the risk and will ease some of those symptoms of bowel obstruction, the bowel obstruction symptoms that we've discussed.
Yeah, perfectly agree with what Alaa has to say.
Mm-hmm.
Yeah.
I think we're still trying to study and see what things would be able to prevent or reduce the risk, but I think certainly a low fiber diet, from what we've been doing and from what we've been seeing, does certainly help.
Great, thank you. This is a question that a lot of people have asked. Without fiber, how does anything even move through your system? My system would simply stop without fiber.
Right. So again, it's not necessarily saying that you're not having any fiber, foods at all. You are having a little bit of fiber foods. And I know from our program as well, Nazlin and Dr. Bhat again chime in, but you are also you're also provided with some a bowel regimen just to make sure that your bowels are moving and are functioning properly. One thing is that it's not just about diet as well, but it's also about physical activity. And that's a part of the equation where we often forget at times. Diet is one thing, physical activity is another thing. And also, thinking about your overall stress and just environment, right? Stress certainly has an effect on your bowels. And so it's thinking about your diet, your physical activity, as well as stress and maintaining a good lifestyle too.
Yeah, I agree with Alaa. Low fiber is the key, and the other key is that we should make sure that a person has not gone on without a bowel movement for more than 48 hours. Good hydration and physical activity will add to the benefits of the low fiber diet and the laxatives. Nazlin, anything you'd like to add?
No, that's absolutely what we tell our patients when we speak to them on the phone as well. Everybody's bowels are different. Some people don't go for 2 days, that's their normal. Some people go on a daily basis. So whatever, usually we tell our patients if it's something happening out of your normal bowel movements, then please give us a call so we can just talk you through it.
Thank you. So again, I have a couple questions here. Sorry, I just got to find them again here. A couple questions here. I have IBS and need lots of fiber to keep things moving. So we've got that from a few different people.
Yes.
Yeah, sorry, no.
Yeah, sorry, Alaa. So Alaa will tell you more about that, but just to start off, two entities, irritable bowel syndrome and diverticular disease, can coexist even much before the cancer was diagnosed. Therefore, for these patients, what we need is a slightly specialized discussion which takes into account their GI specialist, their dietitian, and their oncologist to make sure that their needs for the fiber is dedicated and is tailored to each individual. I think can add to that.
I agree. And especially when I was talking about those fiber containing supplements, for some individuals, they will have to, have those as a part of their as a part of their diet. But that's to be discussed with the team, with the oncologist, with your physician, with the entire team, just to make sure that you're not compromising your health while going on the low fiber diet. So we're achieving a balance for sure.
Again, a couple people have sent in this question. As an ovarian cancer patient, how likely am I to develop a blocked bowel?
Yes, so broadly speaking, we say that bowel obstruction is a common complication in a woman presenting with advanced disease or in recurrent disease. It is common and serious both. That said, it's not 100%. Every person is different. Some people may expect recurrent disease just in their lymph nodes, not as many peritoneal deposits, whereas some may have more of peritoneal deposits. So what I would say is at each visit, when you visit your oncologist and whenever we've had the scans done, it'd be nice to would be nice to go about seeing how have my bowels been moving over the last few days, and the oncologist will go over the scan reports, and putting all this together, the oncologist will be able to tell that yes, this person is at a risk of bowel obstruction and needs more help. I think Nazlin and Alaa can add on to this.
Yeah, I think if exactly what Dr. Bhat had to say, if you're worried about or you want to know what's your risk, then simply ask your oncologist to say, am I at risk of having a bowel obstruction given the fact that I have this cancer? I think just being upfront with your oncologist is really key, and not to be afraid to ask that question.
Thank you. So here's another question. I have had a bowel obstruction. Will I need to stay on a low fiber diet for the rest of my life?
That's a difficult one for me to actually answer. It's difficult to say yes or no. I think I always say take it one day at a time, communicate with your healthcare provider, see how things are progressing and moving. I have had some instances with patients where we were able to expand a little bit on the low fiber diet. Maybe we weren't needed to be as restrictive, but that's a discussion to have, and I can't really answer yes or no, but it's something to discuss and see how things go.
Okay.
Yeah, and I'll just add to that, when we are calling our patients, that is one of the most common questions that we do get asked. And so after having a bowel obstruction, you have to be very careful with the foods that you do reintroduce. And usually, like with Alaa, how she said that we try to see if we can increase the fiber a little bit. but really you have to see how you react to that. So for example, I had a patient who really loved eating salad, and so she wanted to try and see how she felt, and so she did, and she immediately felt the difference in her stomach. She could tell that, okay, this really doesn't agree with me. So you really have to see how you feel when you start to reintroduce your foods, and to go at a very slow pace. But again, the key is to keep in touch with your healthcare team, especially with your dietitian.
And I just wanted to add with that, and that's just kind of stemming off of what Nazlin said. That's why I actually encourage people to keep a food journal, just to be able to see how they're feeling. And when we are expanding or moving our way up on that low fiber diet, I'm usually going very slow with patients, like, incorporating one food from one food group. I like food grouping, just to be able to see, right? A lot of patients will tell me, I just, let's go slow because I don't want to have another bowel obstruction. I don't want to feel what I felt. So again, it's just a conversation to have, and the dietitians, as well as the nurses and the whole care team, will be by your side through that.
Thank you. We're getting through them, guys. Thank you. Here's another question here. So since my surgery, my bowel movements are generally over a day apart. The consistency seems to be fine, and I am definitely passing gas. Is this something I should be worried about?
Yeah, so this one again, what we tell a person to look for is any recent change in bowel movements, and to make sure that they have not gone on without a bowel movement for more than 48 hours or more than 2 days. For some people, it may be normal to have a bowel movement on alternate days, and that's been their pattern always, in which case it's fine. But if they notice a recent change, if they notice that their stools are harder, or they are small, like they're narrower in consistency, or it was going on alternate days, like maybe 5-6 months post-op, and now they feel that, hey, it's 2 days since I've not had a bowel movement, it's more than 2 days, I'm feeling a bit bloated, I've not passed gas as well, I think that's a good time to call your doctor's office and say that I think something's up, could we have a chat or something.
So I have a comment and a question here. Thank you for all of the wonderful information. I sure wish I could have had this information before my bowel obstruction. I'm sure it would have made a difference. The question is, since I have had one obstruction, is another obstruction more likely to recur?
Yeah, so based on what caused the obstruction, and if suppose it was like many dense adhesions or a lot of peritoneal disease, then there would be a risk of another bowel obstruction happening. Hence, to keep a good watch on maintain a journal of the bowel movements as well as what's eaten. Make sure that good oral hydration is happening every day, trying to be as physically active as possible, and any recent change should be reported to the nurse practitioner or the clinic nurse or the doctor. And always feel free to ask for help. Never hesitate. We're always here to help you. Your treating team is always here to help you.
If experiencing symptoms of a bowel obstruction, how long should I wait before going to the ER? A few hours? A day?
Yeah, so if there is concern of obstruction, and especially if it's the weekend or it's towards the end of day, I would say that do not wait. If possible, call in your physician's office, or if it's past that time, it's safest to go to the ER, because what is at most important is patient safety. Never feel that somebody, people will be like, hey, it was nothing. No one feels like that. Every symptom will be valued, and if need be, you will be helped as required.
Here's another question here. I think we have time for 2 more questions. My osteoporosis team advises a high calcium diet, and most of high fiber foods you mentioned are included in this diet. Moreover, anti-cancer diet also has many of these items. How do we go about finding the middle ground and implementing the right choices?
Yeah, I think this, so I think there certainly is a balance to be talked about. Certainly, again, it's not to say that you can't have some of those fruits and vegetables, because you certainly may be able to tolerate them and have them within your diet. I think it's a discussion just to be able to see what you're eating, how you're doing with the dietitian, to be able to sort of bridge both, right? The osteoporosis as well as the low fiber diet. In terms of cancer prevention, in terms of having more fruits and vegetables for cancer prevention, again, you're still going to be able to have more, you're still going to be able to have some fruits and vegetables. But I think the important concern now is to focus on the, the risk of developing a bowel obstruction or whatnot. So you really want to see the balance and seeing how you can incorporate both diets together. I think it is possible, it's not impossible, but definitely speak with your dietitian, speak with a healthcare provider, and ask for a referral if you don't have a referral to a dietitian.
Great. So this will be the last question that we take for today. We've gotten through a lot, so thank you all. Alaa, you mentioned in your presentation to avoid raw vegetables. Is it okay if they are steamed or cooked?
Yes, so of course we highly encourage that all your vegetables be cooked. So steaming, roasting, that is more than fine as long as you're removing the skins, peeling away the seeds, anything like that, that is more than fine. But of course, you're choosing the low fiber fruits and vegetables, to be cooked, to be eaten. So yeah.
Thank you. And thank you all for being with us today. That was a session jam-packed with information. I know we had a lot of requests for the presentation to be uploaded, so we will put that in the session description after this presentation. Also, I do apologize that we missed a portion of that video on the sound, so we will put the link for that video in that section as well. And I think we did get to most of the questions, so thank you again for that great presentation. We really appreciate that.